This seminar is an introduction to diagnostic imaging for the cardiopulmonary system. It will be divided into two parts. 1, introduction to imaging techniques and modalities, and 2, common pathologies. For these presentations, we will review routine radiographs, discuss the indications for additional studies, review the evidence that guides clinical decision-making as it relates to cardiopulmonary imaging, and then in presentation 2, we will identify common cardiac and pulmonary pathology seen in physical therapy practice. We will review the images and clinical implications. Orienting and identifying anatomy. Place the film so the patient is facing you. Their left is on your right. It doesn't matter if the chest view is an AP or a PA, it is viewed the same way. Be sure that the heart is on your right side. The search pattern is an A to J pattern as noted in the text. We look at the airways of the trachea and look for the midline. We look at the bones, the ribs, the clavicle, of the scapula. Look at the cardiac contour and look at a normal ratio of the heart being diameter 50% or less than the diameter of the lungs. We look at the diaphragm, that the right is higher than the left, in the dome shape. We look for effusions. Are the costophrenic angles sharp? We look at the fields of lungs for any masses or infiltrates. Note the gastric bubble in the stomach on the left, the hilum, and the vessels. The inspiration, it should be possible to count the 10 posterior ribs. There's your first anterior rib 1, 2, 3, 4, 8, 9, and 10. And all that jazz is looking for any lines, tubes, implants, prosthetic valves, or foreign objects. Take a moment to review the anatomy. Here we have a PA chest film and an AP thoracic film for comparison. The major differences between the thoracic and chest radiograph is exposure technique. The thoracic spine has high contrast to visualize the bones, and the chest has low contrast to visualize the soft tissue. Image 1 is an erect posterior-anterior chest radiograph. A PA image normally is captured during full inspiration. The PA puts the heart and lungs closer to the image receptor, resulting in less distortion. On an AP view, the heart always appears enlarged, so it is not useful for the purpose of the cardio ratio. Image 2 is an AP of the thoracic projection with increased contrast, allowing for better visualization of the spine, the spinous processes, and the posterior ribs as compared with the chest PA. PA and lateral projections are the standard chest imaging for radiographs. A lateral projection is made in a left lateral position, placing the heart closest to the image receptor. The lateral image is important to identify the location of a lesion that may be seen on a PA. As we've discussed, one view is no view. Take a minute and see if you can identify the anatomy. All PA chest films are taken in the inspiration view. An expiration view may be ordered for comparison. In the inspiration view, in a healthy adult, 10 pairs of ribs will be exposed because the diaphragm moves inferiorly. This will also lengthen the heart and lungs as they are pulled down by the diaphragm. The diaphragm has moved inferiorly and the lateral chest walls appear flattened. An expiration view decreases the volume of the chest noticed by the dome of the diaphragm. These radiographs are often compared to identify small pneumothorax, foreign bodies, or to identify the movement or lack of movement of the diaphragm. The American College of Radiology publishes appropriateness criteria. So the evidence-based indications for imaging for radiographs are to identify cardiac versus pulmonary disease, to identify pathologies that will guide treatment, and to exclude differential diagnosis. Commonly advanced imaging is ordered. This could include ultrasound, CT, MRI, nuclear medicine studies. The indications for these studies would be to refine the diagnosis, to guide treatment or surgery. Here we have an example of a normal coronal MRI image, and on the right you see the location of the scout film to help you identify your location. There are more cardiac MRIs done due to improved technology recently. It is also less expensive and less invasive than a cardiac catheterization. MRI can be more specific to identify non-occlusive coronary disease that would normally be missed on cardiac catheterization. Coronal views are helpful in identifying the size of the ventricles and coronary artery disease. Please take a moment to identify the anatomy. Image 1 is an axial MRI showing the main and right pulmonary artery crossing under the aortic arch. Image 2 is a sagittal MR showing the midsection of the left ventricle and the interventricular septum and the right ventricle. The scout films help you locate the approximate location of the image slice. With both sagittal and coronal views, we can better visualize dilation or dissection of the aortic arch or root. CT scans best identify calcifications and plaques. Image 1 is an axial chest CT scan with contrast. The white arrow shows increased subcutaneous tissue in the right breast. The yellow arrow shows an enlargement of the pectoralis major. And the red arrow shows an enlarged lymph node. Image 2 is a mesothelioma on a coronal CT scan. You can see a large tumor on the left side of the picture. The other lung is black, meaning it's tumor-free and filled with air. Additional studies can be read about in your text that include perfusion studies and nuclear medicine. Nuclear medicine is a medical specialty involving the application of radioactive substances in the diagnosis and treatment of disease. Many images you have seen today come from yale.edu/imaging, which I also highly recommend for further imaging and study examples. When cardiac disease is identified, further imaging is indicated. An echocardiogram is a test in which ultrasound is used to examine the heart. It provides single-dimensional images as well as more advanced imaging. It is capable of displaying a cross-sectional slice of the beating heart, including chambers, valves, and major blood vessels that exit from the left and right ventricles. Doppler imaging shows the color spectrum of blood flow both to and away from the probe as displayed in red and blue. The echo is the primary imaging study for valvular imaging. The two most common types are transthoracic echocardiography, or TTE, or transesophageal echocardiography, TEE. Transesophageal echo is a more invasive but visualizes the posterior borders of the heart. Stress tests often accompany echocardiograms. A coronary angiogram is different than an ordinary non-invasive X-ray because dye is injected into the heart arteries with a catheter. This enables the X-ray to contrast the arteries with the surrounding body tissue. This is used to visualize blood flow. Note the image on the right showing a normal coronary artery blood flow. After an angiogram, bed rest is common. The technique used to perform the catheterization will determine the length of time. Quick reminder, after any heart catheterization, always check integumentary integrity. A small bruise is normal at the site of the catheter entry. You want to be sure this does not expand after physical therapy treatment. If it does, a hematoma can be forming and urgent medical attention is needed.